Good afternoon, everybody. First, I would like to thank the organizers for giving me this opportunity, and also Kaiser Jamil Madam to encourage us to visit this Egypt and present our research work. So, I would like to present a rare balanced translocation between chromosomes 1 and 10 in a female with the history of recurrent pregnancy loss. Next slide, please. So, the loss of pregnancy at any stage can be a devastating experience, and particularly sensitivity is required in assessing and also counseling couples with recurrent pregnancy loss. Next slide. So, miscarriage is defined as the spontaneous loss of pregnancy before the fetus reaches the viability, and a recurrent pregnancy loss is 3 or more consecutive spontaneous pregnancy losses which are clinically recognized pregnancies before 20 weeks of gestation. But as per American Society of Reproductive Medicine, they have defined RPL or recurrent pregnancy loss as a distinct disorder with 2 or more failed clinical pregnancies, and women with 2 losses have identifiable parameters just as frequently as women with 3 or more losses. Thus, evaluation for causes may be initiated after 2 losses also, and ectopic and molar pregnancies are not included into this category. Next slide. So, these are been categorized into 2 types, that is clinical pregnancy loss and also pre-clinical loss. Pre-clinical loss will be before or after implantation, and that will be around 60%, whereas clinical pregnancy loss will be 10% will be miscarriages before 22 weeks of gestation and 30% will be live birth. Next slide. And risk for abortion increases with each abortion. So, 15 to 20% of clinically detectable pregnancies abort within first trimester, and the risk increases 10% with each abortion, with estimated risk being 24% after 2 clinically recognized losses and 30% after 3 losses and 40% after 4 losses. Next slide. And these are categorized into primary and secondary pregnancy loss. So, in primary it will be they doesn't have any live children, whereas in secondary pregnancy loss there will be a live child along with abortions. Next slide. So, these are the potential causes of primary recurrent pregnancy loss, that is genetic abnormalities, anatomical issues, hormonal and endocrine disorders, immune system disorders, and lifestyle and environmental factors. Next slide. So, the primary genetic cause of pregnancy loss is aneuploidy, an abnormal number of chromosomes in the embryo, which accounts for over 50% of first trimester pregnancy losses. And other genetic causes include structural chromosomal abnormalities such as translocations, deletions or duplications, which can occur spontaneously or be inherited from parents. And the present study, I would like to present a rare structural chromosomal abnormality in a couple with the history of recurrent pregnancy loss, and it helps in understanding the clinical and genetic impact of the balanced translocation in a female with pregnancy loss, with focus on implicated genes and their potential role in embryonic or placental dysfunction. Next slide. So, due to shortage of time, I will skip this slide. So, coming to the case history of the couple, a non-consanguineous couple with a history of recurrent pregnancy loss was referred to the Institute for Genetic Evaluation, and the male and female partners were of age 31 and 30 years respectively, with a married life of 3 years, and the reproductive history of the female partner revealed 3 missed abortions during 8th to 10th week of pregnancy, and informed consent was obtained from the couple, and the study was approved by Institutional Ethical Committee. And a total of 2 ml of heparinized blood was collected from the male and female partners of the couple to check the chromosomal abnormalities if any. Then lymphocyte culturing and GTG banding was performed following standard protocols as described by AGT Cytogenetics Lab Manual, and karyotypes were described according to the International System of Cytogenetic Nomenclature. Next slide. And this is the method which I followed for doing the analysis, and here we will be taking the heparinized blood from the patient and initiate in the nutrient media for culturing. Then we treat the colchicine treatment will be given to arrest the cells at metaphase stage. Then we have to go for hypotonic treatment wherein the cells will bulge, and then after that we will be treated with fixative, which is nothing but corners fixative, 1 part of acetic acid and 3 parts of methanol. Then we have to remove the RBCs to get the lymphocytes, and also then we have to drop the cells from certain height so that the bulge cells they broke open and release the chromosomes on the slide. Then we have to go for trypsin treatment and genes are staining to get the karyotype. This is the brief protocol how we do the analysis. Then going to the next slide. And this is the nomenclature for giving a karyotype for a abnormal or normal karyotype for an individual. So here from centromere we will be numbering the regions. So arm region, then the band region will be mentioning for each patient. If there is any abnormality, we will be mentioning as 15q12. Here it indicates 15 indicates the chromosome number, q indicates the long arm of the chromosome, and 1 indicates the region, and 2 indicates the band position on region 1. So this is the nomenclature we will be giving. Next slide. So for normal male we will be designating as 46XY, female 46XX. If there is any translocation, if there is any addition of chromosome, that is trisomy 21, we will be indicating as, since one number of chromosome is extra, instead of 46 we are writing as 47, then sex of that individual XY or XX, then plus 21 if the chromosome 21 is extra in that particular individual. And whenever there is translocation, we will be indicating it as the whichever chromosomes are involved in translocation will be indicated in the bracket along with the breakpoint regions to the another bracket. So this is the ideogram standard with which we can locate the breakpoint regions on the chromosomes. Next slide. And when we did the karyotype analysis for both the male and female partner of the couple, male partner was normal, whereas in the female partner we could able to see the translocation between chromosomes 1 and 10 at breakpoint position Q32 and P14 with clinically normal karyotype phenotype. Phenotype was normal, whereas only chromosomal abnormality, that is translocation, is seen in the female partner. Next slide. And such carriers of balanced chromosomal translocations are phenotypically normal, but more than 50% of their gametes are unbalanced due to abnormal segregation during meiosis, thus forming reproductive disturbances. Then this could occur in 2.2% of couples with 1 miscarriage and 4.8% with 2 miscarriages and 5.7% with more than 3 miscarriages. And the rate of structural chromosomal abnormalities are more compared to numerical chromosomal abnormalities. So this is the origin of reciprocal translocation, whereas there will be 2 breaks in 2 individual chromosomes, then reunion of the exchanged chromosomal segments between these 2 chromosomes. Next slide. And here in this particular case, we have seen the breakpoint regions at arm region, long arm region 3 and band position 2 in chromosome 1, whereas region 1 and band 2 in chromosome 10. Next slide. And when there is a chromosomal translocation, when there will be alternate segregation of the chromosomes, then it leads to the formation of balanced gametes, whereas vertical and horizontal segregation of the chromosomes leads to the unbalanced gametes. When they unite with the normal sperm, then it leads to the formation of a zygote with abnormal chromosomal number, this thing. So for that reason they are at risk for abortions. Next slide. So this is the karyotype of normal male partner, that is 46XY, whereas in the female partner it is denoted as 46XX, then translocation between chromosomes 1 and 10 with Q32 region and P12 region. Next slide. And we have even tested the parents of that particular proband, wherein they were normal male and normal female karyotype constitution in her parents. So this is a de novo translocation. Next slide. So couples with a balanced translocation usually have a normal phenotype but may have infertility associated with oligospermia in males and miscarriages in females. So here in this particular case, since there is unbalanced gamete formation, it is leading to abortions. Next slide. So these are the genes which are missing at this particular region 1q32 and 10p14 region, which are involved in the regulatory processes. Next slide. So these are the genes which are present at these breakpoint regions which are causing abnormal development of the fetus, finally resulting in abortions. Next slide. Next slide. So here it can lead, these are very few reports are seen in the patients, and it is seen 1 and 10 translocations were seen in one case with acute non-lymphocytic leukemia, and here in this particular patient with neuroblastoma, whereas the present study revealed a de novo balanced translocation in a female with the history of recurrent pregnancy loss with 46XXT110, then Q32 region and P14 karyotype. Next slide. So such translocation in the proband can disrupt genes essential for immune tolerance, desudalization and endometrial receptivity and trophoblast invasion, which may impair implantation and early placentation, leading to recurrent miscarriages. Hence, the couples experiencing RPL or recurrent pregnancy loss must be screened for chromosomal abnormalities before any other investigations or medications. Next slide. So genetic counseling is often recommended for carriers, especially when planning to have children, to assess the risk of passing on a translocation that could lead to infertility or an unbalanced karyotype in offspring. I thank the Department of Biotechnology for the financial support for this study. Thank you.